So drug interactions can be split into three different categories. There's physicochemical, pharmacodynamic, and pharmacokinetic. Physicochemical interactions occur as a result of the actual chemical properties of the molecules themselves. So, for example, bicarbonate and calcium will precipitate out of solution if given down the same giving set. So you can't give them together, they're incompatible. Same goes for gentamicin and penicillins. These molecules are fundamentally incompatible and need to be given either at separate times or through separate giving sets. Pharmacodynamic interactions are either direct or indirect. Direct means that you've got two drugs acting on the same receptor system. So, for example, naloxone inhibits opioids. They both compete for the same receptor site, and therefore they directly inhibit each other. Indirect means they don't act on the same receptor or the same pathway necessarily, but they will act on similar clinical parameters. For example, calcium channel blockers and beta blockers will both lower blood pressure through different mechanisms, but you'd say they have an indirect pharmacodynamic interaction because they will both serve to reduce blood pressure. Neostigmine and rocuronium have an indirect pharmacodynamic interaction because neostigmine prevents the breakdown of acetylcholine, and the acetylcholine then competes with rocuronium. So there's an indirect interaction between the two. And finally, pharmacokinetic interactions can be split into absorption, distribution, metabolism, and excretion. For example, metoclopramide and aspirin are given together for the treatment of migraine because metoclopramide reduces gastric stasis and improves the absorption of aspirin, and therefore you get better bioavailability of aspirin, and so it works better for the migraine. These two have a pharmacokinetic interaction because the metoclopramide improves the absorption of the aspirin. Another example would be activated charcoal preventing the absorption of many toxins, and that's why it's used in overdose cases. A good example for distribution is Sagamidex. This is a chelating agent that essentially mops up rocuronium molecules, stops them distributing to where they need to go. So Sagamidex and rocuronium have a pharmacokinetic interaction affecting the distribution of rocuronium. This can also be more indirect, so anything that lowers cardiac output will lower the distribution of a given drug. So, for example, if you've given suxamethonium and labetalol, the labetalol will reduce the cardiac output and slow the onset of the suxamethonium because it reduces the distribution. Metabolism pharmacokinetic interactions are usually as a result of enzyme inhibition or induction, and a classic example is amiodarone inhibits CYP2C9, making warfarin more active. Meanwhile, for induction, ethanol induces CYP2E1, which means chronic alcoholics are much better at metabolizing sevoflurane and will need more sevoflurane for their anesthesia as a result of that enzyme induction. Finally, for excretion, any drug that increases or decreases the excretion of another drug is clearly going to affect its clinical impact. An example would be bicarbonate causes urinary alkalization, which is used in the treatment of aspirin toxicity, as it enhances the excretion of aspirin and means the body gets rid of it much more quickly. Also, if you want extra marks, you can talk about the enterohepatic circulation. So diclofenac relies on gut bacteria for its absorption, and if you give an antibiotic that kills the gut bacteria, you then don't absorb the diclofenac as well. So ciprofloxacin and diclofenac shouldn't be given together because the cipro kills the gut bacteria, which means you don't get so much enterohepatic reabsorption of diclofenac, and therefore it's less effective. The reason this is in the excretion category is because it's the enterohepatic circulation where drugs are excreted by the liver into the bowel and then reabsorbed again. So it's already been absorbed once, then excreted, and then reabsorbed, and it's this reabsorption process that this affects. So the ciprofloxacin will increase the excretion of diclofenac by killing the gut bacteria that would facilitate it being reabsorbed. That's why it's in this category rather than in absorption. This is an overview of drug interactions, the three types: physicochemical, pharmacodynamic, pharmacokinetic, and how you can break down your answer to be nice and structured in the exam.